asthma deaths. For those that don't know, Mark Levy is a GP in London since 1977 with a special interest in respiratory diseases. Mark was one of the 6 founder members and the first chairman and the past editor of the Primary Care Respiratory Society. He's a member of the Junior Executive, and his current posts include Respiratory Lead for Harrow and Clinical Lead for the UK National Review of Asthma Deaths. Heather, for those who don't know her, I've got blog envy. She's got a brilliant blurb here. She's been a nurse for a very long time. For almost a quarter century, she specialised in respiratory nursing, both in primary and secondary care. She leads a fabulous team of respiratory nurses. And she's been a committee member at ARNS. She's a facilitator of the End of Life course. She was a panel member of the National Review of Asthma Deaths and presently sits on the BTS NIV days. She's published in a number of nursing journals.
The types of cases that we were looking at when we were panellists. This is an amalgamation of different ones to keep anonymity or out for the patients. But a female with late onset asthma and the confirmation of the diagnosis was delayed. And this is not uncommon, that people do present time and time again to a healthcare professional, or more commonly a number of healthcare professionals, and that might be across primary, secondary care, with the symptoms, but nobody actually makes the diagnosis. But when she was given spirometry, she had a 28% reversibility. She was started on a low-dose inhaled corticosteroid. Poor attendance record. Does that ring bells with any of you who are looking after people with asthma? Yeah, and that's certainly something that we need to be looking at. I'm sure some of the questions will come up out about that. But she did have an asthma review with the practice nurse. She's waking at night, daytime symptoms, and asthma limited her lifestyle. So very symptomatic. And over the last 12 months, 16 salbutamol inhalers and 1 beclomethasone inhaler. She was advised by the nurse to make an appointment to see the doctor without any advice or changes, and no record of the personal asthma action plan. And the patient died 8 weeks later without ever seeing the doctor. What were the red flag signs there? We need to recognise when asthma is poorly controlled. And only if you know that, as a healthcare professional, what poorly controlled asthma looks like, will you be able to react to it correctly. And that's come through. I was in the confidential inquiry for asthma deaths in the east of England for about 10 years. And this is the type of messages that were coming through year after year after year, that many people looking after people with asthma do not have the skills to do the job. So the nurse didn't appreciate the relevance of the answers to the template about the RCP questions, and didn't see this patient was at high risk of dying with asthma. And clearly, what we all need to do better, and Mark will be drumming this home to all of you, is patients using personalised asthma action plans. So we should be doing a structured review, and when we're doing the questions and answers, I might share with you some of the things our team has instigated since the report. And assessing asthma control every time. And where it's identified, do something about it, then and there. You can't pass it on because that patient may never attend another appointment. So you need to address the problems there and then. So that's all I'm going to say. It's just setting the scene for you, and I'm going to let Mark take over.
Thanks, Eva. We wanted to introduce the afternoon with the story of the patient, because it's quite easy to get to ground in all the numbers and the figures and forget that this study was really about people who died from asthma, and we learned a lot from them. And I personally am very grateful that we were able to access that information. So what would be really good if we went away with 3 key messages. Just seeing all the recognising all the faces that I've known for years and years and years. And it's really a pleasure to be here and a great honour to be here. In fact, we started the Primary Care Respiratory Society down the road, our first meeting was in Blenheim Palace in the King Henry VIII room when we were deciding to form the group. Now, there's three messages to take home really, and you'll see the themes will emerge as we go through the data. First of all, there was a failure by patients to call for help. And I'm not blaming patients. I think you will realise that these patients weren't really warned or told what they should be doing. There's a failure to recognise danger signals, and there's a failure to appreciate that asthma is a chronic, ongoing, relapsing disease. It's not a disease which is a series of acute episodes. And if you look at how many people were managed, they managed as if this was a disease involving acute episodes. And as Heather said, together with that third message was really to assess and gain control. Okay, so the National Review was commissioned by HQIP on behalf of the 4 devolved nations and delivered by the Royal College of Physicians, the Clinical Evaluation and Effectiveness Unit. And lots of supporting partners, and I don't need to point out the one that we're involved with today, but thank you to your involvement. We had a lot of nurses from your organisation, from the PCRS, who helped us with this review. So the aim of the National Review was to understand the circumstances surrounding these asthma deaths in the UK, so that we can identify avoidable factors and make recommendations for change. And the main methodology involved a confidential inquiry. And this involved health professionals such as yourselves coming together in meetings to discuss these cases. And we focused on deaths that occurred during the 12 months from February 2012. So just to explain the process of certifying death, because it's useful to understand that, to understand how we recruited patients. So an underlying cause of death is assigned by the national statistics organisations, like the Office of National Statistics for England and Wales. And that's assigned on the basis of what's written on the death certificate. So where a medical certificate of the cause of death states, for example, death certificates have got 2 parts, part 1 and part 2. So if part 1 states, as in this example, 1C chest infection leading to 1B an asthma attack leading to 1A respiratory failure, it's pretty logical that the underlying cause of death will be asthma. And that's what would happen if that was written on a death certificate. But it's quite hard to understand a death certificate like this, where you've got 1A chest infection, and part 2, all the diseases that the doctor thinks the patient might have had in their whole life. And we had a string of about 13 or 14 diseases on some death certificates. But the way the system works is that because the word asthma is there, it'll trump everything else. And asthma will also be defined as the underlying cause of death in that case. And that's one of the reasons why you will see why we excluded so many cases in this review. So we were notified by the agencies from the 4 countries of death certificates which had the word asthma on them during that 12-month period. We had a few notifications from individuals, families, friends of people who died, and a coroner phoned me once because he was concerned that a case should be included. And I hope that's not me. And so we got a notification form detailing all the particulars of that person. We had this section 251 under the NHS Act 2006, which gave us permission to access data, identifiable data, without getting permission. And so we were notified all the details of the person who died, and also whether this was their first ever attack, and whether the doctor reporting the case thought, the likelihood that the doctor thought this case was due to an asthma death. So we had 3,500 death certificates with the word asthma on, and we excluded 2/3 of those because the majority did not have asthma as the underlying cause of death. And 514 of those cases were excluded were people over the age of 75 with asthma in part 2, even if they were ascribed the underlying cause of death due to asthma. And this is purely because of the workload. It would have been impossible for us to manage all of these patients, and that's why the decision was taken to exclude them. So we included 900 cases, 900 people who died during those 12 months, for possible inclusion in the confidential inquiry. We asked for all consultation data, prescription data, correspondence from primary and secondary care for the final attack. So this was an audit sheet, which I don't know if any of you had to complete these, but quite detailed audit sheets for the primary attack, for the final attack, primary and secondary care, and also for previous attacks for primary and secondary care. So we got a lot of information back. And I went through all the case notes that came back and had to make a decision on the likelihood that this person died from asthma. It's based on information provided by the consultant or the nurse who filled in the form, and sometimes a consultant would write, this patient clearly didn't have asthma, didn't die from asthma. So, they were easy to exclude, but a number of them were quite complex. And so I had a panel of experts, some senior respiratory physicians who helped, two of whom were on the original asthma death review, which the British Thoracic Association published in the early 80s. And so they helped me decide in those complex cases. And one of those experts was Graham Crompton. And as a result of his involvement, we created a new read code. Because, Mark, you'll be interested in this, we found that a number of people were ascribed COPD death. And Graham picked up that there were actually people with chronic asthma who had, what happened was the practice is by a spirometer. They do spirometry on somebody who's had asthma for 45 years, and they changed the diagnosis to COPD. And so we created a new read code, chronic asthma with fixed airflow obstruction. I think it's H355, it'll come up later, but use that read code rather than changing to COPD if somebody's got asthma with fixed airflow obstruction. Okay, so these are the returns and the cases that we ascribed, that we sent to the confidential inquiry. Now, we know how busy doctors are, and yet we find it incredible that in 1/3 of those 900 cases, we either got no data at all or insufficient data to include cases for confidential inquiry. This included 8 children and young persons under the age of 20. So we were really concerned about that. And I think future reviews will probably result in referral to the GMC if practices and hospitals don't participate, because the GMC, the General Medical Council, actually says you must participate in confidential inquiries, and yet 1/3 of the cases provided insufficient data. We excluded 39% as not having died from asthma, so of the 900, 352 did not die from asthma. And then 276 went to the confidential inquiry. So we held 37 panel meetings, 174 volunteer panel experts, and 6 to 10 cases per panel. And each panelist looked at 2 cases, and these were summarized on the panel assessment form, and we reached a consensus agreement with one of the chairs during the meeting. I don't know if Sam Grigmore here today. Sam chaired some of these meetings for us. Now, the panels decided that 195 people died from asthma and made 1,000 recommendations, and is Kaya here today? Kaya Francis is writing up the panel recommendations in a qualitative review. And the panels decided that 60% of those people who died had potential avoidable major factors, and I'll explain what they are. And if you look back in the asthma death reviews, you look back to 1966, when the first review was done, 60-70% of the cases had avoidable factors. It's really with great sadness that I stand here today and say that they haven't really changed. with everything we've done in asthma, we've still got so many people dying with avoidable factors. Now, 45% of the people died at home, 31% in hospital, and 24% died outside hospital. And that included cases where people arrested and they were taken home and certified in the hospital. The duration of asthma was a median of 11 years, age at diagnosis, median 37, and the age at death, median 58 years. The range was from 4 to 97 years. Now, I'll talk a little bit about mild, moderate, and severe asthma. We asked the clinicians to state whether they thought the patient was mild, moderate, or severe. We did define the classification. Severe was really people who had had life-threatening attacks, been admitted to hospital or ICU, or on step 4 or 5 of the BTS guidelines. So we're reasonably confident about the ones that were classified as severe. 58% were classified as mild or moderate, and most of them, we assume, were based on surrogate measure based on the BTS guidelines, the amount of treatment that was being issued. Now, I'm just going to turn this off in case it's me. The definition of severe, the definition of severity of asthma is the amount of treatment required to gain control of the asthma. It's not me. And so you'll see from the next few slides, a lot of people were undertreated. So we think that the estimation of severity was an underestimate in this study, because we think that a lot of people were actually more severe than the doctors thought that they were. So case history to describe, or just illustrate that. This is a middle-aged male. Again, it's an amalgamation of cases, but the themes were pretty common in the cases that we saw. So you've got a middle-aged male who was diagnosed in childhood, classified by his GP with mild asthma, and his last asthma review was 2 years before he died. And at that review, he had clearly poorly controlled asthma and was prescribed low-dose dexamethasone. He failed to attend review appointment for follow-up, but he was seen twice intermittently by his GP for unrelated symptoms. I remember one of the key messages I wanted you to remember is that asthma is a chronic disease. And that doesn't seem to have got through really, after all these years and all the publications. So you've got somebody with chronic asthma who comes in with another disease, and the focus is on that presenting symptom, and nobody's looking back in the records and trying to do some opportunistic work on asthma when people consult. This guy presented again 8 months before he died, saw his GP, and was prescribed amoxicillin for his wheeziness. He saw his GP 3 times further for musculoskeletal problems. Again, no mention of asthma in the records, and he died at home in an acute asthma attack a few months later. Now, during his last year of life, he was prescribed 18 salbutamol inhalers and 1 beclomethasone inhaler. So did he really have mild asthma? Okay, 43% have no record of an asthma review in the last 12 months. 37 people had had an assessment of their asthma control. It's less than 1 in 5. And just under a quarter had had a personal asthma action plan. 77% of these people who died, there was no record of an asthma action plan in their report. And 57%, just over half, were not under specialist supervision. A bit about the beta agonist prescriptions. You'll all be aware that somebody with well-controlled asthma will need less than 2 or 3 salbutamol inhalers in a year. It's 200 puffs in an inhaler, and if you're taking 6 puffs a week, you would need less than 3 inhalers, even if you've got one in your car and one at work. Just under 40% were prescribed more than 12 short-acting beta agonists. 6 people got more than 50. One person got 112. Conversely, inhaled steroid prescriptions, so these are inhaled steroids alone or in combination with a LABA, long-acting beta agonist, And you'll know from the different devices and dosages available, most people would need between 4 and 12 inhalers a year. So taking them at the recommended doses. Some inhalers have got 200 doses in, so some inhalers you only need 4 a year. But 38% got less than 4 inhalers, and 80% got less than 12 inhaled steroid inhalers. So most of these people were undertreated. And so we've recommended electronic surveillance for prescribing in primary care. And it looks like the Department of Health might progress with that. The practices weren't small practices, which is what was expected, and of those practices that return data, the denominators keep changing because we didn't get complete sets of data from all the practices. But of those practices that return data, nearly 90% had full quaff points. And asthma reviews are done by GPs with an interest in asthma, respiratory nurses with a diploma, and 46% without a diploma. And you'll see from the 2 cases that we've shown that we've made this very strong recommendation that people doing asthma reviews should have training. And that includes doctors as well as nurses. Okay, so quick run through the top line results. I said 71% of those people who went to the panels were considered to have died from asthma. So at least 30% of the death certificates and the ARNS classification of the underlying cause of death was wrong. 36% of those people did not have asthma, did not die from asthma even though they had it, and 10% of the cases that went to panel did not even have asthma. So there are big problems with their certification, and this is being addressed at Department of Health level. And we asked the panels to look at routine management of attacks and management of the final attack, and about a third of the cases were managed adequately. And adequately was defined as care which you would expect for yourself or your family. That's how the panels judged adequate treatment. And in the case of the children, 2 out of the 28 that we had data on were managed adequately. Chronic management, 8 out of the 28 in their previous attack, and 13 out of the 28 for the final fatal attack. And a number of these kids were actually treated in the hospital. The overall standard of care, you'll see 31 out of 195 cases had overall good practice. And in the children, only 1 out of 28 children who died were thought by the panels to have been managed according to guidelines or according to good practice. If you look at the major factors that the panels identified, and these are defined as factors that contributed significantly to the deaths, and had things been done differently, the outcome might have been different. And if you look through those major factors, most of these could have been avoided had the guidelines been followed, with the exception of 3 which relate to patient adherence to advice and medication. And as I said before, 77% of patients did not get self-management plans, so it's no wonder that they weren't really managing their asthma. I mean, I remember in the first week that we did this, they were started collecting data. A woman was reported on the front page of one of the major national newspapers, and the woman was quoted as having saying that I never knew that asthma could kill until my husband died suddenly from an asthma attack. And it's just stuck in my mind. It was that first week in February 2012. Now the next few slides just take the main headings that the panels were asked to look at. And so these are avoidable factors related to family and environment. And you'll see that in 65% of cases, the panels thought there were 1 or more avoidable factors, and in the children, more than 90% of the children. So we've recommended an increased level of education for parents and children. The avoidable factors related to chronic ongoing care. 70% of those in primary care had 1 or more avoidable factor, and 29% of those managed in secondary care. And so we've recommended that healthcare professionals should really be more aware of the features that increase the risk of adverse outcome in asthma, particularly the concurrent diagnosis or comorbidity of mental health illness and psychosocial problems. With regard to the treatment, the assessment of the final attack, you'll see that a third of cases in primary and secondary care had one or more potentially avoidable factors, and so we've recommended there should be a named individual in every hospital and every practice with responsibility for ensuring improved asthma care, particularly the care during attacks, which includes follow-up. And then the management of the final attack, again, you'll see about a third of the cases had one or more potentially avoidable factor, and a high number of those children and young persons. And how many of you work in secondary care? Well, the panels were really worried about the use of MID in acute severe asthma. The guideline says that it shouldn't be used, and I don't know what your feeling is about that. And the failure to recognise risk features. We had a number of intensive care specialists on our panels, and we had at least 2 cases where there was a high normal PCO2, which was not recognised as a danger sign by the junior doctor, and it wasn't escalated up to a more senior clinician. And so, again, we've recommended the named individual, but also the use of patient-held rescue medications. And at our launch on Tuesday, a lot of people felt that this should really be more widely used than in people with a previous life-threatening attack. I'm sorry, I'm running out of time. Won't be much longer. The panels identified potential avoidable factors related to follow-up. 10% had died within 28 days of being discharged from hospital, and 21% had been seen in the emergency department at least once in the year before they died. And so we made a number of recommendations with regard to follow-up, particularly that anybody who's had an attack should be seen again. And our guideline says within 2 working days. So we need to make that happen. If you're in secondary care and you've seen somebody, make sure that the practice nurse knows, or the GP knows that somebody's been in with acute asthma, and follow those up. We've recommended those admitted to hospital with acute asthma should be followed up in secondary care, not primary care. So the 3 key messages that I put up initially: failure to get help in time, and you will have seen throughout the data that there are a number of failures on the part of health professionals which could have helped patients to identify when they were in danger, when they should have done something more aggressive. And so we recommend everyone should have a personal asthma action plan. Failure by doctors and nurses mainly to identify the life-threatening risk features, and that relates to prescribing and healthcare utilisation, and we made a number of recommendations to improve that. And the other key message was assess and gain asthma control. And we can see that we have all these people who are treated as if they have mild asthma, and we're not taken seriously enough. And I'll talk a bit more about asthma control, because the GINA guideline was launched on Tuesday as well. My colleagues are a bit cross with me because I think we overshadowed the launch with the asthma death report. But we haven't had time to make slides yet, but the GINA tool for assessing asthma control is really the RCP3 questions plus a question about reliever medication, and identify risks of future adverse events. And you'll see, look at the GINA document, it's online, but you'll see that there are a whole lot of factors that people should be aware of that can lead to adverse outcome in asthma, including incorrect inhaler techniques. In last papers showing if someone can't use their inhaler correctly, their asthma is poorly controlled. In fact, somebody with poorly controlled asthma has 6 times greater chance of having an attack than somebody without. Now, if you look at the report, you'll see there are 19 recommendations. I've covered most of them. There are a few that I haven't. The standard national asthma template, the ongoing audit of asthma, which is likely to happen. They're just fighting about who's going to pay for it. And factors that trigger asthma should be recorded. An assessment of the inhaler technique is absolutely essential. And nurses and doctors need to know how to use inhalers. And we know 60-70% of us don't. So we need to, I know it's not people in the audience, but the rest of the world don't. And then if a long-acting beta agonist is prescribed for asthma, it must be with an inhaled steroid. And then patients should be encouraged to reduce exposure to smoke and allergens. I spoke about the new READ code which we've created. It's H335. And the mean age of diagnosis was 37. This is a new finding, and we recommend research into late onset asthma. Is it, I mean, were these people late onset, or were they just delayed diagnosis? And is this a risk factor for asthma death? And just to remind you that we've known about this for 60 years now. It's time to change. Thank you.